To this incredible group that's attending this webinar. Some of the leaders of industry, program heads from around the country. I'm seeing some international presence as well. I'm really an honor to have a dialogue with you and for you, and start to discuss a way to look at how to keep donor testing safe and efficient and effective and compliant in this new era. We're now looking at nearly 4.2 million people infected with SARS-CoV-2, nearly a third of them in the United States, deaths rising daily. And yet, in the donor gamete world, we have to come up with a framework for really trying to figure out what does testing look like, what is safe, how do we screen donors, and how can we be compliant and create a healthy way for many couples who could not otherwise build their family to build their family. We have with us today Jaime Shamonki. Dr. Shamonki is a pathologist by training. She's also the Chief Medical Officer of the largest reproductive tissue bank in the world, at Generate Life Sciences. She's a friend, she's a subject matter expert, and she's going to help us talk to us today a little bit about how to frame the conversation. I hope nobody's expecting answers today, because we really don't have answers. This is a situation in flux, but we have to learn how to ask the right questions. What are the right guidelines? So to Jaime today, I'd like to Dr. Shamonki, I just want to hear a little bit about how you view infectious disease testing. How much of this is screening in a questionnaire? How much is reactive case detection via direct testing versus antibody testing versus exposure? Can you tell me a little bit, when you keep our tissues safe, what is the guidance that we can have so that we can apply it to SARS-CoV-2?
Great, thank you, Alan, and thank you for inviting me. I welcome the conversation. I do appreciate the caveat that we don't necessarily have answers. If anything, this pandemic has been quite humbling in terms of all of the things we think we know, we don't necessarily know. But we do have new emerging information every day. And we also have, I think, a pretty good rubric when we look at what the FDA has laid out for many years. And so with that, I do think it makes sense to sort of start at the top and talk about what do we do now for donor screening. Those of us who participate in third-party donation are probably quite familiar with the FDA guidance for screening sperm and egg donors for various relevant communicable diseases, or RCDs. But I think it might be helpful to briefly review how we currently mitigate infectious disease risk in donors, and then we can try to think through how the coronavirus might fit into this rubric. So there are, of course, the numerous serology and NAT tests that we currently get on our donors, which are mandated, of course, by the FDA. I'll note that CMV is technically not an RCD per the FDA, but it is required to test for in sperm donors to help eliminate the acutely infected individuals from the donor pool. We are inferring something about current or past infection based on the ability to directly measure nucleic acid, antigen, or antibody. But we're also looking for additional diseases, some of which are RCDs like spongiform encephalopathy, some of which are just, as a community, we've agreed it would be ideal to avoid in donors if possible. It's all about risk mitigation. And so in these cases, we rely quite heavily on a whole host of indirect measures to mitigate disease. So things like travel history, social history, of course, physical exams, and lots of surrogates for high-risk behavior like drug screening and the psych assessments, et cetera. It's very tempting whenever we have an emerging infectious disease to assume that we're going to use a direct test as an approach to disease risk mitigation. But I think it's important to know that it's very specific. It has to be tailored to the specific pathogen. So, for example, we were all recently traumatized by Zika. That's fresh in our minds. It's obviously highly relevant to recipients, but we don't have a specific substrate test. What I mean is that we know we can detect Zika in semen. We know that it's present in blood. It also disappears from the blood weeks before it disappears from the semen, but we don't have a validated substrate-specific or semen-specific test for Zika, which means we're resigned to the FDA suggestion or mandate, that is, to defer donors for 6 months when they have traveled to endemic regions. So it's truly a blunt instrument approach to mitigating risk. Not every emerging disease is going to have a perfect testing solution. The other important thing to think about as we think about testing for coronavirus is that antibody status means different things depending on the virus. So we've all been talking about serology tests lately for coronavirus, and keep in mind, as we think about immunity, when you're testing for CMV, for example, an IgG towards CMV means a very different thing. It likely means that you are immune, certainly in an immunocompetent individual, versus somebody who has HIV antibodies. We would interpret that a very different way. So as of now, empirically, it appears as though people who've recovered from the coronavirus and have seroconverted in areas where there are high rates of penetrance, such as Northern Italy, those people appear to be protected from reinfection, but we definitely don't have enough information now to know if this is absolutely true, and if so, how long that immunity will be meaningful. So simply initiating serology testing in donors it's too early to know if that's even going to be meaningful. And one more point I'll make before we get back to more discussion format is, we have to know what an RCD is. We refer to relevant communicable diseases all the time, but the FDA has a very specific definition. And I think it's important we remember this as we think about introducing new screening measures in our donors. So the FDA defines RCD as it has to be a pathogen that risks transmission by the HCTP. So if it's not transmissible through the HCTP, it's not relevant to the recipient. Also, it needs to have a severe enough effect on the recipient that we care about screening for it. And there have to be available or appropriate screening measures or tests. So there are certain things that we might care about screening for, but we don't have appropriate screening measures to rely on. Perfect example is ureaplasm. People ask me about this all the time, whether we screen for it. And the truth is, of course, it's highly prevalent. We know it can be sexually transmitted, but the reality is it's not an RCD because it doesn't have a pathogenicity to reproductive cell and tissue recipients. On the other hand, something like TSE or HIV-2 are incredibly rare, but we know they pose extremely significant health risks and therefore are RCDs. So just a little sort of rubric to get us started as we think about how coronavirus testing might fit into gamete donor screening.
I think that was just the most incredible overview. Tell me a little bit more about the pathogenicity and cell determination with regard to SARS-CoV-2. And if you could just take me through eggs and sperm separately, and even to throw one more curveball on, about blood. I mean, should we be screening blood donors for these for SARS-CoV-2, or is it just a questionnaire based at this point?
Yeah, again, I'll caveat this with, we don't know for certain, right? And so I would hate to sound too certain or prescriptive here when there's a lot of speculation and a lot of inference. But the key that we need to focus on as we're trying to solve this problem is, what is the clinical relevance in a reproductive tissue recipient? So on one hand, we're going to talk about testing as it relates to our IVF patients, and we're trying to protect the safety of our staff, ourselves, our patients. There's another thing, which is looking at HCTPs, or human cells and tissues, and the relevance of coronavirus in those tissues. So the FDA continues to report that COVID is not spread through human cells or tissues. And, again, we don't really know for sure, but it at least fits with our understanding of respiratory viruses and HCTPs. So because of that, at this time, the FDA does not recommend establishments use laboratory tests to screen asymptomatic HCTP donors. And this is both in the tissue banking industry, cadaveric donors, as well as blood donors, as well as reproductive tissue donors. It does appear as though the SARS-CoV-2 can be detected in blood samples. It's been in a small percentage, actually, of severely ill patients. So the approach now in the blood banking industry is to implement a deferral system based on exposure or symptoms, as opposed to direct measure using any of our currently available testing. And my sense is that as I mentioned earlier, I think the mitigating the risk here is far more about achieving safe conditions for staff than it will be about preventing spread via the reproductive tissue.
Really interesting. So now ASRM last night dropped their next round of guidance, and they specifically talked about donor tissue. And they talked about donor tissue with regard to FDA's April 2nd release. Can you tell me what direction we're going in ASRM, and how do we make these decisions every day when the news comes out about, is there sperm, are there fragments of RNA virus detected in sperm, and what does that mean for infectivity, and should we start testing our donors? So how do we follow FDA and ASRM and our conscience and our local guidelines?
Yeah, I wish I could give you a good answer. So of course I'm not on the ASRM task force. I can't speak for them directly, but I can tell you how I interpreted their guidance and how I square that with the FDA guidance. I think ASRM is very much trying to approach a general achieving safety for all of the various people who are involved in both IVF, the reproductive services we provide, as well as third-party reproduction. And so we're really looking at it from sort of a clinic-centric view of how are we reducing risk to all of the various people who are involved in this important process. And whether that's achieved through monitoring our staff, testing patients prior to procedures, trying to mitigate risk for particularly vulnerable people who have comorbidities. I think that there needs to be an approach that is cohesive and is probably going to be region specific and practice specific. I think reproductive tissue donors obviously fit in very importantly into that IVF clinic's view, but they fit in the way that your egg donors are your patients as well in some respect. And we need to protect the health of the egg donor. We need to protect the health of our staff who are helping to monitor and retrieve egg donors. And so that's when I think about considering introducing testing into the clinic, and what ASRM was referring to in this recent update, it's more about that immediate risk than it is about the tissue. So for me, this is really just my understanding, my sort of basic understanding of biology and pathology and infectious disease spread. I don't see a risk in the tissue itself. If you think about, so you mentioned there was an article recently that came out. It was a little bit hasty. They had to go back and update some of the information. I think people are rushing to get these things published. Where they identified RNA fragments of the COVID virus in the semen of men. Few points there that I think are mitigating. One is these were acutely ill men that had either were acutely ill and hospitalized or recently recovered. So not the kind of sperm donors we would be allowing to donate. We don't really know what the relevance is of finding RNA fragments. I've always cautioned people, if you look for something hard enough, and particularly using PCR, you're gonna find it. It doesn't necessarily mean that it's infectious. And the other thing is, again, we have to apply some degree of logic, which is what's the importance of the presence of ACE2 receptors in the sort of pathogenesis of this condition. So by introducing semen with RNA fragments into the uterus of a woman via IUI, is that really going to have a clinical significance for a respiratory virus? I don't know, but my logic would say probably not. You could take it even more reduced to the absurd and say, what is the likelihood that, follicular fluid is going to confer some risk to an embryo via ICSI? It's a little far out. So my suggestion at this point would be, think about implementing safe procedures for your clinic that makes sense as we're trying to slowly open our economy, slowly open our practices to allow for people to access important care. But I think that rushing to try to test donors when there's no clinical evidence that this is meaningful from a reproductive tissue perspective, I think would be a little foolish.
Good. We have a question from the audience. They're asking us a little bit about about the guidance on egg donor screening. So when we're screening donors, how much of it is questionnaire based, and what if there's a primary contact with somebody who is sick, and if there's still a PUI? Can you talk us a little bit about what the current guidance is?
Yeah, that's a great question. I mean, long before this became quite evidently a pandemic that was affecting the United States as significantly as it has, we implemented guidance through AATB, that's the American Association of Tissue Banks, which was really based on prior similar travel-based guidance. So people who manifest symptoms should be deferred, and that's symptoms, even if you don't know what the symptoms are due to, somebody who's acutely ill should not be allowed to donate at that time. And then there was an additional travel-specific question where we knew if somebody had traveled to an endemic area, whether that's Zika, chikungunya, or in this case that had been clearly affected by coronavirus, those people were being deferred. And then finally, if you had close contact with, and that's there's a definition of close contact for having coronavirus, or if you simply had prolonged contact with somebody who actually had been diagnosed, those are all reasons to defer somebody. And in this case, it was a 2-week deferral. Somewhat akin to the quarantine guidelines that have been implemented by the CDC.
Fantastic answer. And then the framework that we're getting here and basing it on other infectious diseases, other pandemics globally. I mean, this coronavirus is a novel one, but how analogous is it to SARS and MERS? What have you learned studying infectious disease that you can tell us about how you predict the coronavirus? Should we be quarantining tissue when we take out the sperm or the eggs based on what we know about other coronaviruses?
Sure. I mean, we've seen analogous viruses. Obviously, SARS and MERS are the examples. We haven't obviously experienced those in this country the way we're experiencing them now, but the tissue banking industry does respond in a similar manner. So the rule in the past was, just as I mentioned, having a robust system, and this is every time a donor is entering the clinic or entering the branch, if you're a sperm donor donating, there should be an abbreviated, updated social history. So in this case, it's basic questions. Are you feeling well? Have you traveled anywhere? Have you been exposed to somebody with, and whatever the particular virus is at the moment that's relevant, you would ask those questions. So in the past, that's actually how we were trying to screen donors out for SARS and MERS. And even then, it wasn't so much about being concerned about the reproductive tissue having an infectious risk. It was really about protecting all of the various people who are involved in procuring that tissue and cryopreserving it.
Well, let's talk a little bit about that. So now we're not necessarily doing or recommending based on based on anybody, the FDA, based on Department of Health, based on ASRM, routine nucleic acid testing of donors. But some anesthesiologists are saying that before they want to put a patient to sleep, they'd like to know if they're positive or negative, and they want to cancel before the start of the cycle. And that's regionally and locally in different institutions. But fast forwarding it, some are actually saying a couple of days before the egg retrieval, after the donor's been stimulated, they want to retest. Tell me, what do you think about that? Are they painting themselves into a corner? And how do you manage the risks to the donor of hyperstimulation versus any risk of the procedure, or to, as we talked about, low risk to any tissue?
Right. I mean, I think it's all about mitigating risk to the procedure. I totally understand, it's going to be regional, and it's going to be even within regions, clinic to clinic, perhaps hospital to hospital. Having an anesthesiologist have a policy around testing before intubation, I'm on board with that conversation. In terms of quarantining oocytes and testing after retrieval, I really don't see the logic to that. Particularly, we're talking about, RNA testing, PCR testing. That is really a point in time, and it's only meaningful at that point in time. And so the reason why you would test a donor at that point in time is because you're trying to prevent any transmission from human to human within the context of that procedure. From the tissue itself, I see absolutely no sense in quarantining eggs, although it would be great for my frozen egg donor business. I'm not suggesting we move away from fresh egg donation, and I just don't see the logic there.
So aside from the routine PPE, the recommendations, the goggles, at least an NK95 mask, and of course gloves, any other recommendations? Do you think embryologists should do anything differently if they know that a donor has been symptomatic or even test positive for the virus?
Yeah, gosh, I'm not an infectious disease expert and on a level where I feel comfortable recommending different procedures for embryologists, but I would say common sense, and from what I understand from the pathology perspective, using universal precautions is the expectation, and I don't see any reason to change our approach. I think when you're talking about manipulating cells in a clean environment and with full PPE, I am not aware of a way that a respiratory virus is going to jump out of an embryo, but as I started in the beginning, I've been humbled all along by what this virus is capable of doing. I don't see anything to go beyond PPE. I do think that certainly within our sperm donor branches and within all of the egg donor clinics that we work with, I can absolutely say we will be following a physical distancing rule. There'll be far fewer people in a room at any given time. Obviously, the biggest challenges are in New York City and places like that. But that is definitely something we are going to make a change.
So now we promised at the beginning that we weren't going to give answers, and I think we're fulfilling that promise, but that we would give guidance. I'm trying to figure out who to listen to. We've got the FDA, who in conjunction with the CDC has a lot of information. We've got our governors, and fortunately we've been considered an essential service here in New York due to the importance of all of reproductive procedures on patients, so we have some guidance. ASRM has given us not necessarily guidelines or opinions, but they're giving us some guidance too. And each Department of Health obviously has oversight. So what should we be reading, and how should we be thinking about information as it comes in? What advice would you give us?
Yeah, I mean, so state by state, there's different approaches to how we're reopening the economy, and based on that, make a difference in how our various employees feel about coming back to work. So there's a state-by-state difference there. From a regulatory perspective, New York State Department of Health, California Department of Health have actually been, from a reproductive tissue or tissue bank perspective, have really been deferring to and in line with the FDA. So I don't see any discordance in regulatory recommendations. And the FDA has actually been pretty hand in hand with the CDC on this particular issue. So we have relative consistency from a regulatory body. And then there's ASRM, which is trying to accomplish something, I think, much greater and appealing to a much more diverse group of people. So I think we need to sort of read through the ASRM, understand the spirit and the intent of these recommendations, and but I would caution people who are perhaps too eager to test all of their donors. It's actually a caution that I, as a pathologist, particularly when I was a hospital-based physician, I often heard myself say to clinicians, which is only order a test if you know what you're going to do with the information. So I think we need to think very hard about what are we trying to accomplish, what are we trying to do with these tests, rather than order things willy-nilly and then be stuck with information that we don't really know what to do with.
Yeah, and that's such good guidance. So from a nucleic acid testing, and we're thinking about it, we're not yet ready to do a nasopharyngeal swab on everybody that walks in the door. We don't have all the PPE. We're actually not even trained as gynecologists to do anything in the head and neck region. And saliva, where are we with saliva RNA testing? We're hearing reports, but what are you thinking?
I'm hearing that it's becoming more available. What I don't know is how it's comparing yet from a sensitivity perspective to a nasopharyngeal swab. I've heard some reports that it's actually superior, that there's greater viral particles depending on where in the disease you you take the sample relative to a nasopharyngeal, it's probably partly due to the fact that there's a tremendous inconsistency in how those swabs are implemented. So that's pretty great. And then there's the new rapid antigen test that was just approved, which again, I think at the end of the day, we're going to end up with a complement of testing that will put together a clinical picture. But I have seen within my own personal life a few examples of false negatives. So understanding that there's a degree of false negatives out there still with our testing, that it's still so imperfect, I think is another huge caveat as we put together these sort of back to work plans. We need to understand that the testing we choose has to make sense, and we also have to appreciate that it's quite fallible.
And so that's the nucleic acid testing, and we have some concerns over false negatives due to either the sampling technique or just the failure to detect bioparticles, and certainly knowing who really is shedding and how long people shed and spread after the infectivity. We have only a few minutes left, but the antibody testing is also, I mean, everybody wants a free pass, a get out of jail free. Look at waving my card of antibody, and therefore I have immunity. And there's some reassuring data that you mentioned at the onset from Italy, but any cautions that you may want to offer clinics about wanting to throw the antibody positive people at the front line and keep the antibody negative people at the back office? Like, does that make any sense to you as a pathologist?
I understand the logic. I sympathize with first of all, the desire to have a test that confers a hall pass. But we just don't know yet whether these antibodies truly do confer long-term immunity. So even if you have, at this period of time, we have data which is based on a short period of time. This is such a recent experience that even if you look at empiric data from Northern Italy, as I mentioned earlier, this is still only months into this. So it's definitely far too soon to infer that an IgG positive is going to protect you indefinitely. I will say that, relative to what we know about other viruses of this nature, there is reason to believe we should get some long-term immunity out of this, but I would not be confident enough to issue passes or badges of immunity honor, if you will.
Yeah, and I'm seconding that. I mean, I'm hearing in New York State that the rate of antibody testing is actually significantly lower in healthcare workers than in the general population, because we're physical distancing, because we're wearing PPE, because we're wearing gloves and goggles and washing our hands frequently for more than 20 seconds. All of this matters. I mean, we have healthcare on the phone. We've got hundreds of people from around the country on this call. What you're doing is actually mattering. And so in the last question, Jaime, frame how important is, I mean, COVID is a disaster from a global economic health, but every way you can look at it. But when you think about the future of gamete banking and donation, any last words on how important is COVID going to be over the next couple of years?
I mean, I think our response to this is going to set a template for how we respond to the next thing. So I have no illusion that this is the only major thing we're going to be dealing with. I think that it's really important that we keep a degree of sobriety, though, when we have a highly emotionally charged situation. Every single person appears to be affected by this in one way or another, given the pervasiveness in society and the impact of the economy. But I would caution people to not extrapolate the emotional severity and significance in our lives to necessarily superimpose that on the significance to something like tissue banking. I think we need to be slow and careful and use science and apply logic and reason as we put together these plans for how do we change our donor screening procedures, how do we change the workflow in an IVF clinic.
That's a phenomenal way to end it. Thank you, Dr. Shamonki, for being here, for sharing your expertise. Thank you all for participating. We're available. Please feel free to submit any questions afterwards. Bridget is sending the link out in the chat. and really a privilege to be with you all today. And please be safe, everybody. And we look forward to having more answers next time.
Thank you.
Thank you all.